Alright, today we'll go over ataxia. I suggest reading up on ataxia because there's a lot, but ataxia is a failure of muscular coordination, irregularity of muscular action. There's Brunn's frontal ataxia, which is gait apraxia. There's Friedreich ataxia, an autosomal recessive inherited disorder that causes progressive damage to the nervous system, resulting in symptoms ranging from gait disturbance and speech problems to heart disease. It is a triplet repeat disorder in which the repeat expansion interferes with expression of a mitochondrial protein important in iron metabolism. There's locomotor ataxia, tabes dorsalis. There's motor ataxia, the inability to control or coordinate movements of the muscles. There's sensory ataxia, ataxia due to loss of joint position sense resulting in poorly judged movements, the incoordination becoming aggravated when the eyes are closed. There's spinocerebellar ataxia, any of a group of hereditary disorders characterized by progressive degeneration of the cerebellum and other regions of the brain, which with neuronal loss and secondary degeneration of white matter tracts. Those of autosomal dominant inheritance are triplet repeat disorders. Then we have atelogenictasis ataxia. Ataxia telogenictasis, that's a pretty difficult word. Severe autosomal recessive progressive cerebellar ataxia associated with oculocutaneous telangiectasia. Abnormal eye movements, sinopulmonary disease, and immunodeficiency. Alright, that was tough. Alright, ataxia, let's keep reviewing about it, is an unsteady, clumsy motion of the limbs or torso caused by a failure of the gross coordination of muscle movements. Okay. Some list of autosomal dominant spinocerebellar ataxias are SCA1, SCA2, SCA3, SCA6, SCA7, SCA8. SCA1, the incidence is 6%, SCA2, 14%, SCA3, 21%, SCA6, 15%, SCA7, 5%, SCA8, 2 to 5%. The CAG repeats, CAG repeats, and SCA1 are 38 to 83. SCA2 is 35 to 64. SCA3 is 61 to 84. SCA6 is 20 to 33. SCA7 is 37 to greater than 300. And SCA8 is 100 to 250. Clinical features of SCA1 is ataxia, dysarthria, pyramidal signs, peripheral neuropathy, hyperreflexia, cognitive impairment, ocular motor abnormalities is nystagmus, hypermetric saccades, slow saccades, ophthalmoparesis. SCA2 is ataxia, dysarthria, peripheral neuropathy, hyperreflexia, dementia, myoclonus. Ocular motor abnormalities is slow saccades, ophthalmoplegia. Ataxia for SCA3, ataxia, dysarthria, spasticity, Parkinsonism, amyotrophy. SCA3, the ocular motor abnormalities are lid retraction, nystagmus, saccade, dysmetria, ophthalmoparesis, square wave jerks. Okay, so SCA6, we have clinical features, ataxia, dysarthria, sometimes episodic ataxia, very slow progression, lack of family history, ocular motor signs and nystagmus, 60% downbeating, saccadic pursuit. SCA7, we have clinical features, ataxia, dysarthria, retinopathy, peripheral neuropathy, pyramidal signs, infantile phenotypes. Ocular motor signs are saccadic, smooth pursuit, slow saccades. SCA8, we have clinical features: ataxia, dysarthria, mild sensory neuropathy, ocular motor abnormalities, or nystagmus, saccadic pursuit. So with all the clinical features, we have ataxia and dysarthria for all the SCA1, SCA2, SCA3, SCA6 through 8. And for ocular motor abnormalities, there seems to be some sort of saccades involved in all types. Nevertheless, SCA6 average age of onset is 40 to 50. SCA8 is average age is late 30s. SCA2 is involved with dementia and slow eye movements. SCA 1 to 3 and 7 can have earlier age of onset with increased severity from one generation to the next. SCA3, or Machado-Joseph disease, is the most common spinocerebellar ataxia subtype in most populations. The phenotype is one of the most variable among SCAs. The presenting syndromes for SCA3 include pure cerebellar ataxia, familial Parkinsonism, hereditary spastic paraplegia, hereditary neuropathy, and restless leg syndrome. A rarely recognized but common and rather specific sign of cerebellar ataxia 3 is impaired temperature, discrimination in all limbs and even trunk and face, steatoexophthalmos, bulging eyes caused by lid retraction, faciolingual myolemia, and dystonia have been thought to be characteristic but not specific signs for spinocerebellar ataxia 3. SCA3, Machado-Joseph disease, MJD, is an autosomal dominantly inherited disorder with variable expression, but described by Nakano and co-workers in 1972 in an American family of Portuguese Azorean descent. Since then, more families with Machado-Joseph disease have been reported worldwide. 3 different clinical subtypes are described: type 1 with an early onset of 20 to 30 years of age, pyramidal and extrapyramidal signs, progressive external ophthalmoplegia, and minor cerebellar deficits. Type 2 with an intermediate age of onset, and neuropathological examination, degeneration of the cerebellum and the thoracic cord is always present in spinocerebellar ataxia 3, but degeneration of the striatum, substantia nigra, basis pons, ocular motor nuclei, and peripheral nerves is variable. Treatment is, there is no cure for autosomal dominant cerebellar ataxia, no treatment to slow the progressive disease. Nevertheless, supportive treatment is important. Drugs that help control tremors are not effective for treating cerebellar tremors, but can be effective for Parkinsonism, dystonia, restless leg syndrome, and a variety of other neurologic symptoms. Physical therapy does not likely slow the progression of the loss of coordination or muscle wasting, but affected patients should be encouraged to be active. Occupational therapy can be helpful in developing ways to accommodate the patients in performing daily activities. Walkers and other devices can assist the patient to have mobility. Other modifications such as ramps for wheels or heavy eating utensils and raised toilet seats can make patients more independent. Speech therapy and computer-based communication aids often helps as the person loses his or her ability to speak. Although the nature of the specific mutations can help determine the progression, the exact age of onset and the specific symptoms are difficult to determine, especially for carriers with no symptoms. Ultimately, as with all progressive degenerative disorders, the disease is fatal. Persons with spinocerebellar ataxia usually die within 1 or 2 decades after symptoms develop. The prognosis for spinocerebellar ataxia 11 and spinocerebellar ataxia 6 is typically less severe, with very slow worsening symptoms, and persons with SCA8 and SCA1 have usually a normal lifespan. So let's go over some questions. Which of the following drugs is most likely to be helpful in a patient with very slow and rigid rigidity and resting tremor. Would it be carbidopa and levodopa, haloperidol, or diazepam, or phenytoin? Good job. It was carbidopa and levodopa. The third, what radiological feature is most characteristic of spinocerebellar ataxias? When you view an MRI, what would you see? Would it be cerebellar atrophy, high T2 signal in the cerebellar cortex, high signal lateral to the striatum, or a high signal hot cross bun sign in the brainstem? Very good. You see the high T2 signal in the cerebellar cortex. 35-year-old man is diagnosed with autosomal dominant cerebellar ataxia. He has been researching on the internet and knows that autosomal disorders affect each generation and both males and females equally affected. He noted that his grandfather seemed to be affected, but none of his children were affected. What is the best explanation for this finding? Is it a new spontaneous mutation? This is the autosomal recessive spinocerebellar ataxia, incomplete penetrance, or this is an example of anticipation. Good job. Incomplete penetrance is the correct answer. So some clinical pearls. Spinocerebellar ataxia is presented in adulthood, generally as cerebellar ataxia, often with neurologic signs, but rarely with neurologic system involvement. DNA testing can be diagnostic, but clinical correlation is helpful in focus of ordering of tests. Pharmacologic therapy does not alter the natural course of cerebellar ataxia, but can help to resolve neurologic symptoms. All right. So good job, you guys, and I'll keep you guys updated on the next video. And good luck on the boards. Hope this helps. If you have any questions, comment. Laters.